Welcome back to another episode of the Gaslit Truth Podcast. I am your host, Dr. Teralyn, here with therapist Jenn, and today we have a special guest. But before we do that, please make sure you like, comment, subscribe. Send us your Gaslit Truth at the Gaslit Truth Podcast at gmail.com. And I do want to say that this morning we got some really cool news. We are finally ranked number 54 in the United States for
Yeah.
life sciences. So that's pretty sweet. It's like, yay, keeps us going. So make sure
It
you comment
does.
and do all the things to let everyone know that you love the Gaslit Truth. So today
Yeah.
we are here with somebody that we've been wanting to get on the show for a while, and I think it just takes a while to get in the right circles. We are here with Dr. Josef, and
Yes, we
therapist
were.
Jen is
It
going to
took a
introduce.
while. We were waiting for the greatness, and now the greatness has come.
Okay,
How's
yeah.
that?
I'll
All
take
I
right,
it.
mean,
he's
I'll
like,
take
all
it,
there
right,
you
yeah.
go.
humble guy, humble guy.
Yeah.
All right.
Yeah.
So it's really cool to have you here, Dr. Josef. Dr. Josef Witt-Doerring. Am I Doerring? How do I say it?
Witt-Doerring.
Witt-Doerring. Okay, there we got it. Witt-Doerring is a psychiatrist, and he's renowned for his expertise in the field of drug tapering and withdrawal management. With years of experience in clinical psychiatry, he has developed a particular interest and specialization in assisting patients with safe and effective tapering off of psychiatric medications. His approach is patient-centered and focuses on individualized plans that prioritize a patient's well-being and functioning. Welcome to the show, Dr. Josef.
Great to be here.
So I think I came across your social media about was about a year and a half ago, and for me in the arena that I talk about, you were the first psychiatrist that came on the scene that I knew of that was on TikTok. That doesn't mean you were the first one, but you were the first one. And I think I reached out to Jen. I was like, who is this person? Like, who is this guy? And I was
Yes.
so happy to finally see a psychiatrist kind of speaking out, helping people in psychiatry in a different way, because I believe it's so important. And so I think we would just kind of like to hear, and I'm sure you've said that on other podcasts, but let our listeners know what your story is and how you got to this place today from being in very traditional psychiatry. I believe in your beginning and some of your work with medications. So it is your show today.
Sure. Yeah. I guess the short of it is right from the beginning, there were some things that really didn't make sense in psychiatry. I mean, the diagnostic categories, for one, they're not based on any underlying pathology. So you could just report symptoms, and there's no like distinction between, what's pathological and what's like a normal response to things. And we just kept on pretending like it was there were biological abnormalities all the time, and it didn't sit right with me. And I think you end up doing that because the treatments that we use in psychiatry are mostly drug treatments. And as I just stewed on it longer and longer, I realized that a lot of the times we're not really treating any underlying pathology, and then two, the drugs that we're not using them because they're the most effective way in helping people. A lot of times we're using them because they're expedient, because we have a healthcare system where there's insurance reimbursement that incentivizes doctors to see patients in the least amount of time. And so, I mean, there's that thing going on. There's also a lot of pharmaceutical marketing as well, which is targeted at doctors to overhype the benefits and minimize the risks. And I just stewed in that for many years and just kind of going with the flow. And hating it essentially. And eventually I just decided, the way we're practicing psychiatry really isn't helping people, and no one was really talking about it. And so I decided I would start helping people come off meds.
Yeah. It's like it might as well be me, right?
Might as well be me. Yeah.
It might as well be
Exactly.
me.
It might as well be me.
We had another psychiatrist that was on the Gaslit Truth podcast not too long ago, Dr. Kendra Campbell. She calls herself the anti-psychiatrist, right? And we asked her a question, and I got to ask you the same one because it's something that has really intrigued Dr. Terry and I, and it's this idea of a theoretical orientation. Okay. And I just got to ask you about it. So as therapists, right? We
They make us do this.
Yeah, we are like, we base our practices on this idea of a theoretical orientation. So what are the theories in psychology, right, that you do believe in, that you practice, and that really are the basis for how you're moving forward in treatments, right? And so we even when we're interviewed, Dr. Josef, which is kind of funny, and not, this isn't everywhere, right? But like, we will even
Most
be
places.
asked that question,
Mhm.
which it's a really arbitrary question, and it's really stupid, actually, right? But
Mhm.
what is your theoretical orientation? What is the basis, right? And so we asked Dr. Campbell this, wanting to know how this works now that we know that this whole theory that you're chemically imbalanced has been completely debunked, right? So,
Mhm.
in terms of an orientation, how is that, either you going through this, or others, like the field of psychiatry? What do you hinge your practice on then, if the theories that were out there have been debunked?
Sure. Yeah. Well, I'll talk about, I guess, what we learn as psychiatrists. And so what we learn and we pay lip service to is something called the biopsychosocial model, which is essentially just this big thing where it says, there's social factors, whether that's like poverty and environment, there's psychological factors like, the way you relate to others and you communicate and such. And then there could be biological factors like your genes and things like that. And it's a mix of all of these things that make up mental illness. And that's what all psychiatrists are taught. But that's not how we practice. And so the reason we don't practice that way is because there are all of these incentives that push us towards using drug treatments. And so one, I think a lot of doctors will kind of emphasize the biological component because that's helps them justify using the medications. But also just the media, doctors, where we're flooded by always these biological explanations for mental illness because that's what is helpful to pharmaceutical companies. And you're right, when we look at things, let's take depression, for example. Like when we look at what the causes are for depression, all of the studies that have looked at things like life hardship, whether it's childhood maltreatment, social isolation, or stresses, there's a massive effect size in causing depression. All of these very intuitive things that you would think would cause it. And then when you look at markers in the brain, whether it's brain imaging, there's hardly anything there. They don't predict people getting depressed. There's no genes for depression either. And so nor is there any kind of chemical imbalance. And so that all of this biological stuff, at least hasn't been shown to kind of come down to this like neat little piece.
Yeah.
I mean, clearly some mental illness is biological. I mean, there are studies that show that people who have more neurotic traits are more likely to become depressed. These are people who tend to be more self-critical, more questioning of themselves. But that's hard to say that that's like a kind of an abnormality. I mean, everyone knows neurotic people. Some of their traits are quite lovable, and some of them may actually be helpful in the long run because, if it's mixed with things like conscientiousness, they may be more health conscious and they may look after themselves better. And so, even though things like your personality leaning may be polygenic, influenced by multiple different genes, you can't really say it's like this abnormality. And so, that's like depression. And who's to say there isn't some kind of genetic thing going on in schizophrenia and bipolar? There probably is, that makes some people boil over into those more serious states. But to me, it doesn't really, like, yes, I think that could be out there, but where the rubber hits the road with psychiatry is like how you treat the people. And the real issue is like, we use drugs and we tell them that they're fixing these clear underlying problems, but they're not. They're just drugging people. And it doesn't matter if it's schizophrenia, depression, or bipolar. You're kind of using them to just sort of like mask the symptoms. And that's, I think, where your treatment philosophy kind of comes into it. Like, are you using a drug because you're telling someone it's fixing an underlying problem, or are you using the drug because you're trying to like mask their symptoms, which is okay as well. Anyway, that was like a kind of unpacked a lot there.
No, that was
Yeah.
No,
really
you
good.
you
It
you
made
actually
me
brought it right back at the end there,
You
and that's
did.
really what it was.
Yeah.
Like, yeah, there's
Yeah.
this imbalance that you're saying might exist, right? But you're really
Mhm.
not quite sure, because we're not doing. It's not as though, as a psychiatrist, you are scanning the brain every single time that a medication is being prescribed, right? Like, that's not a thing, right?
No,
Right.
no, not at
Yeah.
all. I mean, it's just based on symptoms that someone reports. I mean, you could get diagnosed as being depressed because you just lost your spouse, or you could be diagnosed as depressed because something just came out of nowhere and took
Yeah.
over. There's no
Yeah.
I
there's
guess
no
I guess
brain
there's like
scan.
no
You
typical
know?
human response that should actually be atypical based on lived experiences, right? Like it's all lived experiences. And I think
Mhm.
I want to ask a couple of questions here. So you were talking about the biopsychosocial model of psychiatry, psychology, whatever. Jen and I just did an episode on social contagion and how that might relate to mental health. And I just kind of would like to know if you have any thoughts on social contagion being part of mental health. Yeah, go ahead. He laughed. If you're
Yeah,
not watching
yeah, yeah,
YouTube, he's chuckling over here.
There's a
So
smirk.
yeah, yeah.
yeah,
No, I mean, I think it's a huge thing, and I mean, like if you hang out on mental health is like it's like having a mental health problem these days is trendy. I know that's probably an
Mhm.
unpopular thing to say, and this is not to say that the people who are reporting that they're like depressed or bipolar or anything like that aren't suffering. I mean, I'm sure they are, but when you constantly hear about like mental illness, whether it's on TikTok or social media or on TV, um, it's very easy to latch onto that. Like, oh, what is this thing? This like kind of romantic idea of bipolarism, where like sometimes I'm okay, and then sometimes I'm unpredictable, and then I do these things, and it's kind of crazy. Um, it ends up being this way that you can make sense of things that aren't going well in your life, whether it's your ability to kind of stick with something, or relationship problems. You can start to self-identify with mental illness, and you see it all around. I mean, we've got people on TikTok, they're just like, this is my laundry list of meds, look at all these drugs
yes,
that I take, this is life with bipolar disorder.
Yes.
And I feel, yeah, there's a huge amount of self-diagnosis these days because it's trendy, whether it's with bipolar disorder, ADHD,
big
and
one.
also things like being on the spectrum as well is another big one that I see. And yeah, so I think people are always going to latch out to ideas that are kind of floating around in the ether, that are in the zeitgeist at the time, to understand their experience. And cool, if that's a mental health problem, maybe that would be okay. But usually what goes along with that is like a lot of drugging, which can totally mess someone up, and that's where it becomes dangerous, because the drugs are rarely the answer to the reasons that the people are having problems.
To a social problem, often.
Right.
Hmm.
Drugs are the answer to a
Hmm.
social problem. So,
Right.
and I think that social problem of isolation, loneliness, and a sense of belonging, to the wrong group, perhaps, right? To a group that you can identify with who are also in the mental health world of things. And so, kind of shifting topics a little bit, because you mentioned ADHD. Um, there is such a huge push for ADHD right now, not just in our children, but in middle-aged women. I see a lot of menopausal women suddenly having ADHD. And I'm like, of course, if you get a stimulant, you're probably going to feel, stimulated. So, what are your thoughts about that? If there's not is there a neurological piece to ADHD? And my thought on all of that is, if there is a neurological piece, why aren't we testing for that to see if it's actually ADHD before we're prescribing to our kids and now our women? So what are your thoughts on some of the neurology behind ADHD and stuff like that?
Yeah. Well, there is no signature for ADHD in the brain or blood test. That's why we if we had it, we would test for it. We would use it. So there's no
Mhm.
consistent biological sign there. And then I would say that ADHD, when I see it in kind of children, and then when you see it in older adults, to me that speaks to different things. Like I feel like the whole ADHD in like younger people is tied up with being productive and being academically successful, and just the massive pressure that's placed on people to go to college and succeed and get these jobs and perform and all of that,
Also compliance. I want to add in
and
compliance.
compliance and being able to like kind of sit still in a classroom. And yeah, you end up having a lot of people who do that. They drug themselves and they end up in jobs which aren't suited to them, and they find out later on, and it's the saddest thing. If they come off, they're just like, well, this is not the right job for me. I actually hate this. And it's like
Yeah.
you're in debt and you're supporting like a family at the time, and that's a scary place to be, to kind of drug yourself into a role.
Mhm.
And so then,
Man, you are
but
just
when
getting all the high points.
Yeah.
I'm so sorry. It's kind of
No,
close
you're
to
good.
home. I'm
Jen's
sorry.
like, I'm
Yeah.
regretting every
This
movement I've
is
made in my
not
life.
about me right now.
Yeah.
I know, but I've talked about this, so I'm really
Yeah.
glad you're saying it because it's
Yeah.
validating. So you just keep chatting.
Yeah. With older women, people going through menopause, or people later in life who get this, gosh, I worry about misdiagnosis. I worry about dietary problems. I worry about side effects of other drugs that they may be on, because they genuinely may have gotten to a place where you're like, hey, I was like functioning well, and now I just feel clouded, and I feel like I don't really have motivation to do things. And so I wouldn't be thinking, oh, you just developed ADHD. I would start thinking that we need to give you a thorough medical and dietary workup to see if we can get you feeling well again, because
Mhm.
otherwise it's just just kind of throw stimulants at someone who's got this other problem going on.
Mhm.
Yeah.
It's funny because I always, my poor mother, if she would listen to this podcast, like I throw her under the bus all the time. Years ago, she was prescribed stimulants post pregnancy to lose weight, and she's like, it felt so good, and my house was clean, and I was so motivated and full of energy, and I lost weight, and I'm like, yeah, you checked a lot of boxes of what women want today. Same
Mhm.
same type of
Yeah.
boxes, only that will come today with a pretty hefty diagnosis. And so I was glad to hear you say that there are other things that well, not just women, but children, women, whatever, should be
Mhm.
looking at or could be looking at, instead of, I have ADHD, the response is a stimulant
Yeah.
medication, and that will solve it for the rest of my life. And so then I also think about long-term implications of psychiatric medications, stimulants, all classifications. Can you speak to some of that so people can understand, like, why we talk about some of this being so dangerous and we shouldn't be prescribing in such a flippant manner, because there are long-term consequences, and what are some of those consequences that have been researched?
Sure. Yes. So the scariest thing about psychiatric medication is the clinical trials that look at them. Most of the double-blind trials, they go for 2 to 3 months, and when they do these like extension studies on top of them to kind of just
Mhm.
sort of see how effective they are, they usually go out to about a year or something like that. That is not a long time. I mean, I know that sounds like that might be a long time, but with the median duration of antidepressant use being 2 years and most people being on them for decades, we don't really know the effect that these drugs are having. And so, um, I mean, I can talk to you about, let me talk about, I guess, some theoretical effects first. So the central nervous system doesn't finish maturing until your mid-20s to late 20s. I mean, the serotonergic system is still going through development. That's why younger people have so many more side effects on these medications.
Mm-hmm.
And so long-term effects, I mean, what is going to happen, if you get on a medication when you're a child and you kind of take it through this period of CNS maturation where your brain is developing? We don't know. I mean, we can make some hypotheses from what we see in the animal studies, because what we do with rats and mice and dogs, we give them these medications, and we do see changes in them. We see behavioral changes in some of them. And now it's hard to know how much of that translates to humans, but it's enough to make you wonder, what are the effects that are happening? And so when we have to think about the effect on the developing central nervous system, and we don't really know, but the animal studies point that there is probably an effect there. And then when we go over now to talking about long-term effects, just in general, the neurotransmitters in our brain, they don't just act on our mood, they coordinate multiple functions in our body, whether it's our immune system, our cardiovascular system, our gastrointestinal system. These are the chemicals that control our body. And so when we modify them, now the body is going to push back against them to kind of counteract those effects. And that is going to cause further changes in the brain. And so what I see with people who take these meds long term, and this is all anecdotal because there's no studies, is I see some people and they're lucky and it just hits the sweet spot. They never fully adapt to it, and they just have kind of a therapeutic effect on the drug, and they're just fine, and it lasts for a long time. Mostly what I see long term, though, is actually people saying, I don't really know what this drug is doing. I took it for a while, it worked okay, and now it's just kind of hanging on for the ride. I don't really want to change the dose because I don't want to go any higher, but it's not really doing anything. And then you also have a group of people where it starts to make them worse. They start to develop something called tardive dysphoria, which is just a title that we've given to people who become chronically depressed after they take these medications for a long time. They feel very apathetic, flat, they lose motivation, and it's just having this changing effect on the brain. You also have people, especially on sedatives like benzodiazepines or the Z drugs, they start to develop obsessive thoughts and mood instability during the day. And so there are a group of people who just seem to be getting worse. And these are the people that I treat in my practice, that the drugs have essentially turned on them. So that's what I see happening long term.
You just said something, and I'm hoping I can loop this in. There are side effects that occur, right, that are short term and sometimes longer term for people. In your history, in your prior life, before you were doing the taper clinic, you had a job for an outfit by which you were doing some research for some of these drugs.
I've heard about this.
Are you okay to share that truth? Because
Sure.
I think for you noticed some things and you were not given the stage to be able to write this out in research and be able to offer this to physicians so that they had awareness that this was happening. Can you share that truth?
Yeah. Yes. I mean, so after I left my psychiatry residency, I was upset that we weren't talking about side effects, that I thought were real side effects, whether it was protracted withdrawal, PSSD. And I really wanted to understand how drug regulators and pharmaceutical companies determined whether a side effect was real. So I went to the FDA, and I also worked in the pharmaceutical industry for a couple of years as well.
Like a mole.
And so that's
like a mole.
Yeah. 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 Well, I wasn't like fully, I would say, disenchanted yet. I was just like, maybe there's something I don't know. Because I was so junior when I left. I said, I believe these things to be true, but maybe the experts at the FDA will teach me something. And gosh, I mean, the truth that I would share is that the drugs are nowhere near as there's nowhere near as much oversight as you think there is by the FDA the drugs, especially when it comes to long-term risks. So when I was at the FDA, we would get all of these reports coming in about these different side effects. And what I found a lot of the time was, just with the volume of them, was that the reports that people were sending in really weren't getting looked at very well. Let's say someone had schizophrenia and they took a medication and they had a suicide attempt. More often than not, most of the time, it would just essentially get written off, unable to determine if it's due to the underlying condition, and so the way that the medical officers at the FDA followed up on these adverse event reports really was quite lacking, from what I could see, and that was really disturbing. And we spent most of our time just focusing on drug development projects for the pharmaceutical industry, helping them get the drugs on the market. And when I went to the pharmaceutical industry as well after that, this is not a surprise to anyone, but clearly there's a commercial incentive there to make sure that all doctors see the drug in the best possible light. And so it's almost like the threshold for identifying something as a side effect would keep on rising up. The more detrimental it would be to the drug, the more pressure you would have from people within the company to say, well, are we really sure about this? We don't want to discourage people from using this. And I actually think you would just do better in a drug company, even if you're in a safety role, the more you aligned yourself with the interests of leadership in just saying, well, this doesn't quite cross the threshold because it's a very inconvenient one. And we also I also saw multiple times, so after a drug comes onto the market, there's a label out there that describes the risk from the clinical trials. But then there's a whole kind of, I would say, marketing apparatus within the company that tries to get information out there to doctors. It's solely focused on the benefit at that point, even though there might be risks of the drugs that might be really important for clinicians to know, and that would really help patients. They're not going to publish anything on that because, again, it would sow confusion and hesitancy amongst the doctors. And so what you see over time is just that the drug companies just put more and more positive stuff out there, and no one's kind of holding them to say, hey, you need to talk about the negative as well. They don't do that. So, my whole impression of the drug company and the FDA, my impression of the FDA is that people are asleep at the wheel there when it comes to safety things, and they just kind of go with the flow. And within the pharmaceutical company, they're trying to sell drugs.
Yeah.
And so, yeah.
I want to ask you about, because we were talking a little bit about warnings and adverse events and things like that, like the black box warning of your antidepressants and things like that. So many people dismiss these warnings as, well, they had to put it on there because whatever. Like, could you talk a little bit more about the importance of those black box warnings, or the lack of importance? I don't know. Do you believe them to be important? Do you believe them to be diminished? What are your thoughts?
Yeah, so they've been massively diminished. They are really, really important. So it's kind of like, the analogy I would draw is it's kind of like smoking and lung cancer. How, if you know the history of that, it played out over several decades, this concern about cigarettes being associated with lung cancer. And essentially the company selling the cigarettes would hire experts to essentially sow doubt on the relationship. They would find some study and they would say, well, this study actually shows, it's not an issue. And that's what's happened with the antidepressant and suicidal behavior thing. And at its core, what the risk is it's really simple and it's really intuitive, and I think it would make sense to a lot of people. Not everyone responds to drugs in the same way. You could have 5 people smoking some cannabis, 4 people are relaxed and they're giggling, 1 person becomes paranoid. And we don't know why that person had that paradoxical reaction. It's just something that happens in humans. All people, out of all the people who take the drug, some may respond in a negative way. And that's what's happening with antidepressants. I mean, you give them to depressed people. Most of them are going to have the normal therapeutic effect, which is one of some kind of emotional constriction and blunting, which can be experienced as therapeutic by some. But some people are going to become more agitated and more depressed. They're going to have the opposite response. And so that's what people found throughout the 90s when Prozac started coming onto the market, was that it was pushing some people, even with mild depression, into becoming more suicidal and acting on it. Eli Lilly right now is probably the most valuable pharmaceutical company in the world. That company was created on Prozac. That it was a small company before Prozac came along, and then it became a $1 billion company that's now making that weight loss drug. I can't remember. It's not Wegovy. I think it's the other one. But it all started with Prozac. And
Manjaro?
Yeah, it might be Manjaro.
I don't know.
It's that weight loss one everyone's taking. It's in the news all the time.
We were just talking about Manjaro before you came on here,
Yeah.
so we've got Manjaro on the
Yeah.
brain right now.
Yeah.
But yeah.
Anyway.
Yeah. And then they talk about like the face that it causes. It's like the something face, and it's like all these like hollowed out people, like because they've been taking the weight loss drug.
Ozempic.
People. Ozempic. There you go.
Yep.
Yeah.
The
Ding, ding.
Ozempic face.
Yeah.
Yes.
Yeah.
Side
And
note.
Squirrel.
So yeah. Anyway, so Eli Lilly, essentially, they hired a whole bunch of, well, there were internal people, and there were also people associated with the company to find all of these like epidemiologic studies where they looked at, thousands and thousands of people, and they would say, well, we don't really see the risk in these big studies, but when it came down to what was happening in the people was that there were some people, it was just tipping them into suicidal behavior, and the FDA eventually saw that, and then they put that warning on there. But there's still an army of people out there that are saying, it's overblown, it's not real. But I can assure you, it's just a paradoxical reaction. It doesn't happen that commonly, but if it does happen, it's serious.
Well, and I think, we, in our efforts to avoid suicidal behaviors and, people ending their lives, especially children, it's so weird to me that you would give someone something that is a risk, that heightens the risk, even if they were not suicidal before, and suddenly they become suicidal when they're on these medications. And, we've done a lot of information about the Joey Marino story, which is an extreme story, but a story that needs to be told because there's many people that have that, and so many people still dismiss it as a one-off, or, well, if we have to lose one person, we save 20 others, and I'm like, that's so weird to me to think. Right? You're shaking your head like, no way.
What does that
Yeah,
mean?
that people believe that, that
Yes.
people believe that these medications save lives. And
Yes.
I mean, you can pull it up in the FDA label. I mean, there are more suicide attempts in populations under age 25 on the drug than off the drug. This is placebo-controlled trials. The exact same groups. They come into it the same. You put one group on the drug, they're more likely to attempt to take their lives. When 25 to 65, that group, adults, we'll call them, no change. It's just neutral. There's no life-saving. There's no change in suicidal behavior. And then over 65, they actually do see a slight reduction in behavior, in suicidal behavior. But for the most part, I mean, we're talking for age 65 and below, the clinical trial evidence from the FDA in the drug labels, there's no survival. There's no decrease in suicidal behavior. In fact, there's an increase in populations 25 and under.
Yeah, well, I think there's a lot of fear. There's a lot of fear mongering about suicide right now, about, saving our kids from suicide and things like that. And I think the drug companies have rushed in with, this is what needs to be done anyway. Take this pill. Again, it'll save your child. Years ago, there was a antidepressant. I think it might have been Zoloft. Anyway,
Mhm.
commercial, and my son, I think he was under the age of 10 but over the age of 5. He was in there somewhere, and he was watching this commercial, and he turns around and he looks at me and he goes, "Sometimes I get sad," you know?
Oof. Yeah.
Yeah. And I was like, and then he mentioned something else that was in the commercial too, and he goes, "Sometimes I feel alone." I think that's what it was. "Sometimes I feel alone." And then he said, "Maybe do I need that? Like on the TV, do I need that?" He didn't know what it was. Do I need whatever it is that they're selling, right? And I just about lost my mind. I was like, originally I was like, we talked about it, of course, but I thought, man, this marketing is crazy, and my young son is picking up on these normal human experiences as being abnormal, and there needs to be a solution for that, you know?
It's such a bait and switch, right? Because when I
Mhm.
watch the ads, the first half it's beautiful. It's so
Yes.
empathetic. It's like, hey, do you ever feel sad? Are you going through something? It's tough. People don't realize what's going on. And you're just like, yes, yes, yes. So like finally someone that understands me. And then you get this bait and switch, and it's like, well, it might be due to a chemical imbalance. And don't worry, there's a drug called Zoloft, and
Yeah,
it's going to help.
exactly. No worries here. Or
Yeah,
or the
yeah,
or the ones where you're already on something and you might need something more, like
yeah.
this one will help you if you're already on drug A. Here's drug B, and that's
Mhm.
going to do the same thing. And I'm
It's
like,
the booster. All my clients call
yes,
it the booster,
the
and I got
booster.
a
Or maybe
booster.
because you've been
Mhm.
on, drug
Yes.
A, that you are so terribly blunted by it that, you're neutral and you feel like
Yes.
that's more depression, or
Yes.
maybe.
Yes.
And so I think, our this is going to sound kind of weird. Are psychiatrists just asleep at the wheel here? Like, what is going on? Do you,
Some
what
of
do you
them,
think is
some I
going
mean,
on?
some of them. Yeah, I mean, some of them are. Honestly, I talk to a lot of psychiatrists because I am one,
Yeah.
and there's a big group of people who absolutely hate the system. They see that they're incentivized to not really help people and to just kind of dispense drugs, and they see the limitations there, and they go, well, and patients just come in. They just come in asking for the drugs, and you want to help, and
With other things.
and so there's some people who are really, I think, quite conflicted about what's going on, and they a lot of the times they end up in private practice doing their own things so they can be in more
Yeah.
alignment. But then there's just like a lot of people that just kind of go with the flow, and they're just like, hey, I've got like a mortgage and I have kids and I have this job here and these are my RVUs and these are my incentives, and I'm practicing in line with all of the guidelines that have been developed by the academics who kind of work
Sure.
with the pharmaceutical company and are fully in that thing, and they're just saying, this is safe to me, I'm not going to get sued doing this, and this is just a job. And I think they don't care, or maybe they're just shut off, they don't have the ethical dilemma because they say, well, who am I to really question the way things are being done? This is for the experts, and I'm just going to practice kind of in alignment, and I'm not really going to think about it too much because I'm going to just enjoy my life and spend my time
Mm.
with my family,
Well,
and they
that's
just go with
that's
it.
just it.
Yeah.
Once you hit that space, especially that ethical space, and I know we've got a lot of providers that listen to our podcast here, and Terry and I have talked a lot about this, right? You almost have like two options once you get to that space, which you've been here. Otherwise, you wouldn't be doing what you're doing either, right? You either choose to see that other side, which is extremely dark. It's something that academically we weren't taught. We were not exposed to that side of it, right? And you hit a truth where you go, okay, so I can either stick with this curiosity I have and understand it more, but that's a very dark space to be in because typically it also equates to some form of action because you start to go
Mhm.
down that path where I'm going to have to do something different because this really bothers me so much, right? Like I'm at a point where I have a hard time even labeling somebody with a diagnosis, Dr. Joseph. Like I was taught to like praise the DSM.
Oh,
Okay,
yeah.
like this was my world. I mean, that's all we did
Mhm.
was consultation on diagnoses
That is
in my old
literally all
job.
we did
That's
when
all
we
we
worked.
did. I mean, I would spend, I mean, I slept with that damn book next to my bed. Okay. And like, I
Yeah.
know it's really neurotic, right? When I look back on it, like I was so brainwashed. Right. And now I'm going through, right. And as many people don't know, insurance requires that if we are taking insurance, that we have to label somebody, right? And now I sit here and I'm typing my notes out and I'm doing my dictation. I'm going, well, gosh, I mean, I can't label you with that because it could be hormones. I can't label you with that because it could be trauma. I can't label you with that because like you've been on 14 drugs in your life and I don't even know the impacts that have happened from those drugs. The depression that you have might actually be an adverse effect of the Lexapro that you took. And my whole brain goes into this web. And then I'm like, well, shit, I can't even diagnose you.
Yeah.
But it's this deep space though you get into and it's almost like you can't turn away from it once you're there. And I think some people start to see that, but then they go, there's a lot of risk in that space. There's a lot of darkness in that space. And sometimes just being status quo is comfortable. And so I'm just going to kind of stay there, if that
Well,
makes,
there's a lot
makes
of
sense.
professional isolation in that space too, like and professional judgment from others too.
Yeah.
Have
Yeah.
Oh
you
yeah,
run into
yeah.
that? Yeah. Mm-hmm.
I mean, I would be getting it all the time when I was posting more frequently on X. I mean, that's kind of where we hang out. And I mean, there's a group of pretty vocal psychiatrists like myself on there. And I mean, I mean, you're constantly under criticism from senior members of the profession saying, you know, I mean, they say, you're dangerous. What you're saying, it's stigmatizing patients. It's just, you're harming people. And I mean, essentially, what it feels like is, when you talk about these things, there are some people who simply they do not want to hear it because it's too painful for them to I think, kind of grip how bad things are going, that they try and censor you, and then they try and do it by just coming at you and just saying, oh, you're stigmatizing patients, you're a dangerous person, and all of these things. They essentially try and shut you down by attacking you and your character.
Yes.
And a lot of that happens.
Well, Jen and I talk about that as a lot of consumers do that too, right? So
Yeah.
the consumers in the industry will be, you're dangerous, this is hurting people, these meds save lives, all
We
this
get that a
stuff.
lot.
And
Yeah, I get that a lot. It saved my
yes,
life.
yeah,
It saved me from walking into the ocean. It saved me from, these very dramatic statements. Because it saved them.
mm-hmm.
Yeah,
And I
but
think
it's not coming from a place where it's like, if they really wanted to help people, it would be like, hey, this saved me, and this is upsetting that this happens to other people, and there can be two
yes,
sides to it.
that.
But the energy it comes with, it's an energy of censorship, and it's saying like,
Yes.
I'm going to shame you into just not talking about this other side of it. It is not about helping people get an accurate message. It's about shutting down ideas that make you feel uncomfortable.
Yeah.
100%, and dismissing that there could be an alternative for many people. Like the experience of many doesn't exist and it can't exist, and we can't shine a light on it because that will change the narrative. And that might change my own personal narrative when I do that. And so Jen and I have also started to look at that when we get comments like that of, that person has still probably been very injured by the system and hasn't come into that awareness of that injury yet. And I say yet because
Well,
it'll probably happen.
and and then one of the things that I think that I am so impressed by, I mean, impressed is like the wrong word, but I'll explain it anyway. It's like how the pharmaceutical company has almost politicized the issue of medications. It's not really a scientific issue anymore. It's like the mentally ill are stigmatized. There are these people out there who are trying to scare you away from the medications and tell you that, this is a moral failing and you need to pull yourself up by your bootstraps. They present that they paint the people who are critics of the current model as having these agendas. And mental health and drugs, it's more of a political issue now than a scientific one. And that's why you get these people who say this stuff where it's just like, you're killing people, it's been crafted by these messages, and this comes all the way back to like Prozac and the suicidal the suicide thing. I mean, one way that they dismissed it for 15 years, right? Because it was noticed in 91 and the boxed warning wasn't there until 2006. So that's 15 years. And they dismissed it because they essentially said this is just some Scientology nonsense. They just said, this is being put forth by the Church of Scientology, and they just want everyone to go to their church.
Know that. That's interesting.
Yeah.
I didn't know that.
Yeah.
Okay, go ahead. Yeah.
Yeah. No, well, I mean, it was brought up by legitimate scientists, but then the Church of Scientology was just like, yeah, we actually also think that's true. And, we've always been suspicious of psychiatric meds. But what the mainstream media did was they kind of brushed aside all of the legitimate academics who were bringing up the issue and just said, don't you see, this is just Scientologists out here, and they're in it for their own agenda.
Yeah.
And it worked. And that's what PR does. That's what the media the media groups within the pharmaceutical industry do. They kind of politicize it, again, because it's helpful to sell the drugs and protect the product.
Right. The mental health stigma. So, I'm old. So it used to be that the mental health stigma was, it's shameful to get help for your mental health. And now to me, it seems like it has kind of flipped into it's shameful to not take medication. That's where the stigma is. You're stigmatizing people by telling them that they don't need to take medication when clearly that they do. And so I feel like the stigma isn't that there's not enough treatment anymore. The stigma is the type of treatment that you promote, right? So it's stigmatizing to not promote medication as the treatment for mental health. That's the stigma today, I think,
I don't even understand like what the fuck people are saying. Sorry for swearing when they say it's stigmatizing. I'm like, do you even know what that word means? Like with this particular thing, it seems like a slur they throw at you, because it's like, something like a lot of the things that we tell people are really empowering. It's like, hey, medication may not be what you need. There are ways to kind of get out of this. This is like an empowering message.
Yeah.
But somehow it's thought to disadvantage these group of people and to put them down. All that we're trying to do is empower people to have a better life, but I don't know. It just seems stupid. They just kind of like throw it at you all the time.
It does. I agree,
because we get that word a lot.
Yes, whenever someone says you're stigmatizing mental health, I'm like, I'm what? Like, I'm trying to tell you that there's other ways. Like, if that's stigmatizing, like there's other ways to do this.
They just don't like what you're saying, and they just throw it at you.
Yeah.
Do you get that, Dr. Josef, when you have patients that come to your space? Do you find that you have to almost like they're ready to make a change or want to deprescribe, right? But are some of them in a space where you have to literally deprogram what that is for them by way of either like education, by way of like them better understanding like the etiology of this drug, where it came from? Like, is there the barriers that are still there, right? Because it's like, I'm ready to deprescribe, but I want to get off this, but it's saved me, and you almost got to undo what they've learned.
People who come to me, they're already pretty much there. They go, they have a deep feeling that being on long-term medications is not working for them. I've tried these things and it's not going well. But they usually come to me in this place of like, but I'm afraid, what happens if I stop sleeping? What happens if I become suicidal again?
Yeah.
And that's like the scary part, is because they've gotten used to just bumping the dose or taking another drug when those things have happened. And at that point, it is scary, because what I tell them is, hey, I don't know what's going to happen when you come off this drug. I'm going to try and do it in a gentle way. The only thing I can tell you is that whatever comes up, I will be there to figure it out with you. And that's usually enough to kind of nudge them into it. If they're ready at the precipice, just that acknowledgement that, we are walking into the unknown here, and we are going to need to learn some new things together. But you're not going to be doing it on your own. And I've done this with hundreds of other people, and we'll be able to do it together. And so it's just kind of this reassurance, because they won't learn that they can function without drugs until they actually have the experience of doing it. And so that kind of comes over a long period of time as they're coming off the drugs. So I get a lot of that. I get a lot of people that really just need that reassurance to know that they're not going to be alone, and that, hey, whatever day you need to kind of reach out to me on my team, we will be there, and we will kind of make sure that you get through each step as we go.
Sure.
I think of also too, like I've been working with a lot of people on this too, and I found that giving them a sense of like self-awareness, liberation from what they knew to be true before, and also just like their own intuition plays a huge role in their recovery, allowing them to be independent people again and not dependent on their prescribers and dependent on all these people, but learning to come into their own again, and rely on the self to understand a little bit more deeply about how they can live and be through the process. And then in the end, it's not just about like, listen to what I have to say and do the things I'm telling you to do, because that's how they got here in the first place. It's like start listening to yourself again, finding that voice inside of your head again that is you, that can come forth again. And I do think for a lot of people that voice has been muted and blunted by medication a lot, so they're just kind of existing in their life.
Yeah.
But they do need to have that. I'm going to go back to that word empowered that you said, this self-empowerment, to be like, okay, I can do this. I can learn. I can grow. I can be who I am. And then you have to deal with the the other side of it is that I don't know who I am without being on these meds anyway. Like, Jen and I have talked about this. Like, she was put on a medication at 18. Like, who is she as an adult woman without this medication? That is a whole different world
Who the
of
hell knows?
enlightenment.
Still
Yeah,
figuring it out.
exactly. It's still figuring it out.
Yeah.
It's like
Yeah.
it's arrested development, if you will.
Yeah.
Yeah, and I know we talked about it, Jen, when you came on my show, but you went through a lot of the things. Discovering who you are, but also there can be a lot of problems there for people. I mean, I see some people who are just like, how did I end up in this relationship with this person? This is a terrible relationship. Yes. Or why am I doing this job, which I've built this whole career around this thing that I absolutely hate? And like a lot of the things that led to you kind of getting on the drug in the first place. I mean, some of them are gone, but some of them may have been there waiting or even festering and worsening, and they've just been kind of just covered up. And so you get all of that to sort of figure out on the way off the drugs, as along with like the whole like identity confusion, and that's why, one of my coaches, Trudy, she just celebrated her 5 years off psychiatric drugs, and she had like ECT, multiple antipsychotics. She's one of my coaches. It's like a rebirth. They celebrate it as if it's a birthday now, because when they look back at kind of the person that had come off the drugs, their whole life trajectory has changed. It's a massive deal the day that they come off the drugs.
Yeah.
Well, I mean, that's like recovery birthdays, right? Like
It
people who end
is.
drugs and
I mean,
alcohol.
even during your tapers, right? Like I celebrated 1 year and I was like, holy shit. I had this, we went out to dinner. I had this big party, right? And I'm a year into it. And I know it'll probably be at least another year or more that it's going to take me to get out of it. But that's a celebration. I think there's something that you're kind of encompassing too, when you guys are both talking here about deprescribing. And even when how I describe it to my clients when I'm working with them is this idea of like, the easy part is, let's look at the charts we've put together. Like, okay, we're going to go down by, 0.25 of a milligram or whatever it is, right? Like that part isn't the difficult part. It's everything that goes along with you figuring out who you are, experiencing relationships like for the first time, experiencing intimacy for the first time, feeling emotions the way that you feel them for the first time. It's like these big, huge lifestyle changes that you also have to be willing to work on in tandem with the actual act of taking you down a dose, because that's actually the part that's the easy part is how I describe it. And it's the
Mhm.
other stuff that is really the hard shit that you have to work through or actually experience for the first time because you haven't experienced it.
That's 100% true. I would say 5% of what I do is the technical stuff.
Yeah.
The rest of it is just creating a bubble for someone to have withdrawal symptoms and anxiety and feel their emotions again and feel safe enough to keep on going. And that it's very time consuming. It's very hard. It's very taxing for the staff. I mean, we love doing it and we love our mission, but that's what deprescribing is. I mean, a little bit of it is the technical stuff. And you got to get that right, don't get me wrong, but the rest of it is just creating that container for people to come off.
Yeah.
I love that. I love that. And I think that that's probably a really good place to end the show today.
Yeah, that was good. I like that. Create the container. We wrap up right there, huh?
Yes,
This is
deprescribing.
fantastic.
Well, Jen talks about deprescribing as deprescribing your life, not just medications, but deprescribing areas of your life so that you can bring in what you actually want. And I like that a lot too. So thank you
Thanks.
so much, Dr. Josef, for being here.
Yes.
This is wonderful because I've been wanting you on the show for a long time. So
Yeah, I mean, we've been girl fanning on you for quite some time,
you're on our
and
list of
yeah,
people we want on the show. So we can
yeah,
cross you off, but maybe
yeah,
we'll have you again because there are still some things I'd like to talk to you about. So we'll keep that line open.
I'd love to come back.
Thank you so
Thank you
much.
for
And
thank you
if
for
you
being here.
are
Yeah.
listening, please make sure that you like, comment, send us your Gaslit Truth at the Gaslit Truth Podcast at gmail.com. You can find us wherever you listen to podcasts and over on our YouTube channel, Facebook, and Instagram. Thanks for joining us.
Yeah. Thanks, everybody.